So today we are going to talk about HER2 positive disease. And traditionally we have been talking about HER2 positive in terms of 3 plus or fish amplified disease. With the advent of newer therapies, particularly TDXD, we have realized that lower levels of HER2 positive disease also respond to this particular drug. So what we are basically now talking about are cases that have 1 plus or 2 plus expression of protein by IHC. These patients do quite well with these newer agents, partly because of the design of the new drug, by which the toxic agent associated with the antibody is released and causes death in not only the cancer cells that are expressing HER2, but in the adjoining cells. So this has changed the concept of what HER2 positivity is. And so now we refer to these lower levels of positive as HER2 low. Now, how low still is not well determined. We are talking about 1 plus and 2 plus at the current stage. But as we go along, it may be the cutoff might be 0, some positivity as in greater than 0, and then 3 plus positivity, which is your traditional positivity. We have breast tumors that express ER or PR and HER2. And then there are other tumors that do not express any of these three biomarkers. And these tumors are commonly referred to as triple negative breast cancers. Now, within triple negative, there's a large variation in terms of tissue morphology, DNA mutations, as well as other biomarker expression. As we are now seeing, there are a small proportion of cases of triple negative that express low levels of HER2, that is HER2 low. Then there are other cases that are responsive to TROP2 directed agents such as sacituzumab. So the landscape of triple negative tumors is changing quite rapidly. In addition, there are mutation specific therapies that can be used. So PIK3CA mutation can be seen in triple negative cancers, and a number of other mutations that have now been targeted specifically are now seen or observed in triple negative tumors. So the landscape of triple negative tumors has changed quite dramatically. The pathology is still lagging behind in terms of histomorphologic classification, but with the introduction of NGS and a number of other biomarkers, we might see differences appearing in terms of tissue morphology and treatment. One classic example of it is PD-L1 expression. Expression of PD-L1 has been used to select patients for immunotherapies. So now we have at least 3 different classes of patients who might respond to various forms of therapy. We have the immunotherapy based on PD-L1. We have HER2 low therapies or TDXD based on the expression of low levels of HER2. And then we have non-biomarker selected therapies such as TROP2 expression based therapies. And then additionally, we have other classes of tumors that may or may not have expressions such as PIK3 kinase mutations, AKT mutations, and a number of other drugs that are being tried out in this particular form of disease.